Thank you. So my focus for this, I will continue where you stopped, talking about evidence-based practice, and where do we go from the clinical work. I've been one of these lucky music therapists who actually could go to a university and study music therapy at a study that was already there. At that time in Denmark, in Aalborg, it was a 4-year study when I did it. And I finished my studies in '89. And then I worked for some years with adolescents and children. And then in '95, there was this position in a nursing home at what we call a gerontopsychiatric ward. So people, elderly people with different psychiatric problems. And it was very close to my home. I could actually go there by bike. And I thought, well, this is nice, but I don't know anything about this elderly population. But I got the position, and I really, really came to like this job and to see how with the music, it was like pressing a button, and then you really could see the identity of this person when you use the music. And then in the end of '99, I suddenly got the possibility to do my doctoral research. And of course, in a gerontopsychiatric ward, we have a huge population of different problems. And at that time, it's 15 years ago in Denmark, in Northern Europe, people with dementia, especially those with frontal lobe damages, or where you really see agitated behavior, they came to these wards. And this has changed during the last years. Now they would go more to special units where you have people with dementia together. So the focus for my research was dementia, and especially people with moderate to severe dementia. So that's where I'm going to focus now on this. It's been interesting to see many different journals with different professions actually wanting to put a focus on music, and also asking the question, is music helpful? And this is also based in the problem that dementia care constitutes an unresolved problem. We can't heal dementia. We can give medication, but it can only somehow prolong a period where you have less cognitive disturbances. But we can't cure dementia, not yet at least. And we have many different medicals or medications for dementia, but we see really, really many side effects, and there are still many aspects that we can't treat in dementia. And I think that's also why different professions really ask this question, could music then be a tool to reduce agitated behavior, to when people really become isolated, can we use music then? So there have been, and this is just an example from the journal Aging and Mental Health. In their 8th issue in 2010 in November, they had this focus on music. Okay, I'm too close to it or whatnot. But of course, for my interest is not only if music is helpful, it's also is music therapy effective. And there I think the first place, at least in Europe, is to look in the Cochrane reviews to see, is music therapy effective? And the Cochrane reviews, we heard a very nice presentation yesterday by Wendy McGee about Cochrane reviews, and I think there were several presentations also referring to Cochrane reviews, so I won't go into depth about that. But they are systematic reviews on primary research in human healthcare and in health policy. And right now there are 6 reviews on music therapy. There are more reviews on music as well. I just included those on music therapy. And the general conclusion, there are really interesting conclusions on these reviews, but the general conclusion is that we need more randomized controlled trials if we want to ask this question, is music therapy effective? So the last study here, you see by Wink and Bergsten from Holland. They did it in 2004, and they just recently have what do you say, uploaded? No, yeah, updated their review, yeah. And in this updated review, they have included 10 studies. So almost 400 participants, people with dementia, are included in these 10 studies. And we really have some very, very interesting studies here. I would not go in detail with all these studies. But nevertheless, the conclusion on this review, still in also 2011, is that the methodological quality of these studies was generally poor, and we could not pull the results for further analysis. So when our colleagues, our medical doctors, occupational therapists and so on, when they read this and they ask, is music therapy helpful? Some might say, okay, no, it's not helpful. And they might not understand what it's actually saying here, what is the conclusion. It's not that it doesn't work, but that we need more research in order to be able to ask this question, is music therapy helpful? But it is a problem for our profession that I think too many might misunderstand this conclusion and think, well, then music therapy is not helpful. So indeed, we need more research in this field. So for me, as a music therapy researcher, there is this demand on more RCT studies. But I'm also a practitioner, been working in the field for many years, and somehow I know it's not possible to make an RCT study with this population. And here I want to refer to the gunpowder example by Colin Robson. He's a social researcher, and he wrote the book Real World Research in 2002, I think, and there's an updated version. And in this gunpowder example, or he also called it the realist explanation, we have an action and we have an outcome, and that's very easy. So if we see we have some gunpowder up here, and if we put a match to this gunpowder, we will have a big explosion. So that's very clear. And that's also when we apply a certain intervention, for example, music therapy. This is our action, and then we will have an outcome, and we can measure that, and we can say, is there this outcome or is it not there? But then the realist would say, well, but what about if we didn't put the match in the right position? What if it's raining too much and our gunpowder got wet, and if it was not the right mixture in this gunpowder, maybe it was just coffee powder or something else, we just couldn't get it, we couldn't have this explosion. What then? So the real world researcher or the realist would say, our reality is too complex, it's too diffuse, we have to look at the idiographic situation, at the single person maybe, or the single situation, in order to understand our explosion or our outcome. So we can say there's no cause-effect relation. In the real world, we can do that in the laboratory. So here we can make our experiments, and we might say, okay, if we do this, we will have this outcome. But this is not possible in the real world. And we as clinicians, we know we are in the real world. It's not possible just to say we have this cause and effect relationship. So if we want to make an RCT, we really have a problem here. And I think many healthcare professions think this, and also Charman and Barkham would agree on this, that not all questions in healthcare research, in healthcare and in rehabilitation can be addressed by RCTs. And maybe we should propose a practice-based evidence as a complementary paradigm to the evidence-based practice. Because we as clinicians know that we have to look at the practice, we have to include these inductive process thinking when we do research. And it's also important for clinicians that we own our data, that we understand the data, and that we can generate evidence from our routine practice, that we don't have to change what we normally do in music therapy so we can make research, because then it's not the real world anymore. Then it's not the normal interaction we have with our clients if we suddenly do something else in order to do research. So they would say that we need both paradigms, and that the aim for all practitioners and researchers. It is the best practice. So we somehow have to balance between these two paradigms. And then, of course, some would say we can't have two paradigms. It doesn't work, then we will have a new paradigm instead, where we mix methods in order to be able to answer our questions. So this question, does it work, where we have a cause effect, is not enough sometimes for music therapists. We also need to understand how does it work, and that's where we need mixed methods, and we need to have these mixed paradigms. So in a collaboration with Garmut in Grieg Academy in Norway for music therapy, they started a network for people working in elderly care and invited me as a researcher to take part in this network. And from the beginning it was very clear that we wanted to do research, but how could we also involve the clinicians in this network in our research? And how could we somehow combine practice-based research with research-based practice? So maybe this is very naive, but we had very, very nice discussions on our meetings, 2 meetings every year since 2008. So in this study that we then wanted to focus on, there are many other activities in the network, was to look on dementia. And it's a neurologically degenerative disease, also as defined by the ICD-10. And what we also heard from you about dementia, we can just summarize the impairments that we have, impairments in emotion state and perception, and also that cognition, memory, and attention is influenced when you have a dementia disease. It's influenced in very, very different ways, and we have many different dementia diseases. And what maybe is the most important thing to focus on when we work with dementia is that people with dementia really have difficulties in interaction and in communication with other people. So that's where we can work as music therapists, and where we have to go in and put a setting where it's possible to interact with others. So for this research, it is an ongoing research, and we have done data collection in fall, and we have just finished data collection here in springtime. So when I come back, there will be a lot of number of more data to include in this. I just have the very preliminary results from the fall data collection. So what we do here is to have a randomized control trial is a part of the research, but it's also, we have much more data than just that. So it's a 2-group randomized waiting list control. I'll come back to that. But it's also where we have multiple cases, and where the clinicians also describe their case studies and include this in the study. So we have quantitative as well as qualitative data in this research. And the independent variable, if we talk the RCT, is individual music therapy. Each participant will have 12 sessions of music therapy in a period of 6 weeks. So it's a really intense period. Because we know sometimes there is a deterioration with people with dementia. So if it's too long, it's also a thing to consider when you do research. And then we compare this with a waiting list. People who know they will have music therapy, but they just have to wait 7 weeks. And what we are measuring on a dependent variable is quality of life. And there are different measures for quality of life. And here we choose to use the Alzheimer's disease-related quality of life. And why we choose this was also because then the research assistant or I could phone contact staff. So we would make a phone call, and we would go through all these questions together with them. Because we know from clinical practice, nurses are so busy. And if you just give them a questionnaire, it's my experience also from previous research, they don't have time to fill out the questionnaires. And we miss all our data. So we thought here, we simply will make a really clear agreement with them, and we call them, and up to now we really we don't have much missing data in this way. And here we could use RDRQL. Then we measure agitation. And the reason for including this as well is that it's really a big problem at the wards, people with dementia in the nursing home, people showing agitated behavior. So we thought this is maybe also important to say if music therapy can reduce agitated behavior. And here we use the Cohen-Mansfield agitation inventory, where there are 29 items that you then rate on a 7-point scale. And we also take in data on medication to see if there are changes in medication. And then we have qualitative data. So that's the music therapy descriptions of methods, of goals, the evaluation of the goals in the music therapy, and then short case description, or if they want to, longer case description. But it's also up to the clinician how much they want to use this data from the research, maybe for publications, or maybe to present at their nursing home to the other staff. And for the method, normally in RCT studies, you would have a very precise method because you need to control that. You need to control all the variables. But we know from clinical practice this is not possible because a person with dementia, you have so many different individuals, so we cannot say you have to work this and this and this way. So instead, we try, after each session, the music therapist would fill out just a one-page form and fill out what they were doing in this session in a very easy manner. So again, music therapists are also busy people, so it has to be manageable and to be done in a very short time. So for the clinical method, we worked a lot, at least in Denmark and also in Norway. We are very inspired by the work of dementia researcher Tom Kitwood and his concept of personhood. And also here, what Porges say, that if music therapy can trigger the circuits of social engagement, it will not only support affect regulation and social interaction, but also promote health, growth, and restoration. And you can find more about the clinical method in the voice work book. It was launched on Wednesday, the book by Felicity Baker and Silke Ulich, and launched by Jessica Kingsley Publishers. So in this chapter 6, there is more about the clinical method. And there the method is on voice work, on singing, but in this study we also include improvising, dancing, or maybe just going for a walk, doing other things in the therapy session. We want to know all these different things. So again, it's important that we did not have a clinical manual. So the participant or the music therapists doing this data collection are not restricted to change their normal way of working. And the participants we included in the study were people suffering from dementia who had a diagnosis of dementia and moderate to severe dementia. And just 15, 20 years ago in Denmark, many people with dementia would not have a proper diagnosis because somehow you think, well, people get old and they are a bit confused, but that's normal. But now we know it's not normal, and we know to have a precise diagnosis if people get confused and don't remember anymore. So we can have this diagnosis now. They should also have a referral to music therapy, and it could be by the team, by the doctor, by nurses, and also a described referral. And then also that they show agitation or social isolation. So the first data we took in, if we just look at the clinical method, just very overall, we had 12 people who participated in music therapy. And just from the very first data, we see that most of this music therapy happened in the own room of the person. They have, in Denmark, in Norway, every person living in a care home would have their own living room or their own apartment. And I think this might be very, very different from other countries. But most of the music therapy sessions would happen in this room. But there would also be some sessions, 15% happening in the living room and the lounge. So there might be other people although it was individual therapy. But for some people, they might not like to go into the room, so maybe the therapist would just sit there doing activities but focusing on the one person. And there were also other things, other places where the therapy would take care. And just very overall, what is happening in the session, we could see that singing was what happening, almost 30% of the sessions. So singing seemed to be very popular with people with dementia. But also improvisation would take place, dance movement, where you sing and you move to the songs or to the music, listening together to the music, and also other things would happen, maybe talking would happen in the sessions, in these 12 sessions. And in these 12 sessions, they had a mean number of 11 sessions almost, and a range from 8 to 12 sessions, those who were included here. And the session as a mean would almost last 40 minutes, and the range here was 30 to 61 minutes.